Thank you so much. So, my background is as a pulmonary physician, and I've been working quite a few years with home mechanical ventilation, and obviously also seen a lot of ALS patients in that context. So, this afternoon I'm going to share with you some very simple facts regarding respiratory failure in ALS, and also show you some very simple statistics that we have gathered rather regarding ALS, the status in Norway. And as you may be aware of, and of course there were a lot of patients here at this conference, so and also with the ventilator, and respiratory failure is in fact a major cause of complaints in the ALS patient, and also the major cause of early death, unfortunately. It is a fact that from the point when a patient actually has developed respiratory failure, if you don't do anything, treatment, then there's a very short life expectancy. Perhaps only 15 to 20 months from the point where you have diagnosed respiratory failure. Now, with treatment, and the most common treatment all around the world is the simple treatment, the non-invasive treatment, which I'm going to talk a bit more in detail about gradually, will obviously prolong the life expectancy. Of course, that may not be the most important thing to the patient, because the patient usually has a lot of symptoms of this respiratory failure, so you would treat those symptoms as well. But in addition, of course, you would live longer also, because you are treating him for this respiratory failure. If the patient chooses tracheostomy, the life expectancy increases dramatically. But of course, then there are a lot of things to be said about tracheostomy as well, and we are going to talk a bit about that at the end of the speech. So, treating respiratory failure does do a lot for the patient regarding very painful symptoms like dyspnea, which is shortness of breath, and it also reduces the consequences of this particular kind of respiratory failure, which we call hypoventilation. I will try to explain a bit about that as well. By instruments that you could try and measure quality of life, and this is of course a very difficult aspect to talk about, but there have been instruments developed trying to measure actually the quality of life, and it does seem also that this treatment improves quality of life. It increases lifespan, and fortunately also it has been shown that very few patients actually regret that they chose to receive this treatment. But that of course must be an important fact. Now, there has not been published a lot about quality of life regarding ALS patients here in Norway, but actually there is one paper published last year in the Medical Association of Norway, the journal, regarding this aspect. This is from the Ullevål sykehus in Oslo, and regarding patients using ventilatory support, they actually found that they scored high on mental quality of life, despite being very disabled physically. Meaning that although the patient had a very progressed state of the disease, actually treating their breathing problem meant a lot to their mental quality of life. They were able to show this, and of course there's been a lot of other international publications showing the same thing. And these two publications are very crucial, I think, to the doctor to know about. It's the two papers, one from the European and one from the American Association of Neurologists. They are both very comprehensive reports taking into account all the published literature regarding ALS, actually all the aspects, and of course the respiratory problem is only a small part of this, but it is also treated very comprehensively in these two reports. And one of these papers, in fact, states regarding respiratory management, it says that respiratory care presents the greatest challenge for the ALS patient and the clinician. And deciding when to initiate non-invasive mechanical ventilation, that is mask ventilation, I will talk a bit more in detail about that. Initiate non-invasive mechanical ventilation is critical because of the risk of either sudden death or ventilator dependence without proper advanced planning. So an early understanding of the patient's preferences will help ensure careful and timely planning. Of course, as in all difficult aspects, if you like, of medicine, being able to plan ahead is of crucial importance. Now I'll talk a bit very simply about the problem as it is regarding respiratory failure in the ALS patient. Now the purpose of the lungs, of course, is to be the place where gas exchange can take place. We need to get oxygen from our surroundings, and we get to get rid of carbon dioxide, which is the result of metabolism in the body. And the most important pump or muscle to do this work is the diaphragm, which is the muscle you can see moving here, and the air in and out of the lungs. Of course, the gas exchange takes place far out in the lung, and there's a lot of things that can go wrong and can cause a problem with gas exchange. You need to have a proper circulation through the lungs. You need to have proper or ordinary functioning airways, but of course also you need to have the pump, the muscle that is going to do the work with getting the air into the lungs needs to be functioning. And respiratory failure is consequently actually only inadequate blood gases. The lungs don't do the job that it's supposed to do, and of course a lot of reasons could be for this. Perhaps most commonly we think about asthma or a severe pneumonia that could cause respiratory failure. A heart problem might do it, but in our case now the main focus of this talk of course is the motor neuron diseases and obviously ALS. And the problem once again is that if the ALS patient has affected the muscle that is going to do the respiratory work, and in particular the diaphragm, then you will have a respiratory failure. And this particular kind of respiratory failure we call hypoventilation, which actually is a patient that is healthy regarding the lungs, but has a reduced power to make an inspiratory effort. So you can't actually breathe deep enough. So it's a lack of ability to maintain adequate blood gases due to diseases outside of the lung. And this causes the level of carbon dioxide to increase in the body, and the oxygen levels also to fall gradually. And the problem usually starts first while asleep, because when you are sleeping, the control of the ventilation is poorer. And also when you sleep, you have the disadvantage of lying usually, which makes it more difficult for the diaphragm to do the work that is necessary. Because if I'm sitting, I have somewhat help from the position. I don't need to use so much power from the diaphragm to get the air into the lung as if I'm lying, when I need to move the stomach as well. So these are some very simple reasons why it's more difficult to breathe while you are sleeping. And we can measure these levels and say quite exactly what kind of levels are pathological, should not be in a normal situation. And of course, if this function, the pump, is reduced, we can support it by mechanical ventilation. That's the whole idea. If we use some kind of device to substitute the lack of the muscles to do the inspiratory effort, we can press the air into the patient, and then we can substitute this function that has been reduced. However, there are several different problems regarding respiration in the ALS patient. It's not only the ability to inspire inadequately that we have now explained can cause hypoventilation. You may also have a problem with expiring, and in particular with the problem of expiring rapidly to make coughing possible. So if the muscles over the abdomen is weak and I'm not able to generate enough pressure rapidly to press the air out and cough, then I will have problems with getting the secretions, the mucus in my lungs, out of the lungs, which is of course a very important matter. And to be able to cough adequately, also need to have a proper function of my throat muscles. I need to be able to close the epiglottis, Adamsäpplet, and generate this pressure and rapidly relax the muscles of my throat to get this coughing ability. And all these things together will can cause respiratory problems. So we need to think about all these matters when we are seeing the patient and see how we can best help. The symptoms of respiratory failure in ALS patients. It's a long list of symptoms. These are the medical terms, and I will explain very briefly. Dyspnea, as I told you, is the sensation of breathlessness. And it depends on how rapid the disease develops, whether a patient can actually feel this or not. If the disease goes very slowly, very often it's not so much of a complaint. But the more rapid the disease develops, the more common you will have the sensation of breathlessness. Orthopnea is the sensation of breathlessness when I'm lying on my back. And this is due to the same cause that I mentioned, that when I'm lying on my back, my diaphragm, mellangulvet, is working more heavily. I don't have the same power to breathe deeply when I'm lying on my back as when I'm sitting. Because I don't get enough air during night, my sleep is going to be of a much poorer quality. So I'm going to wake up a lot more and feel a lot more tired during the day. These are very, very common and important symptoms for me as a doctor to know whether the patient has had when he comes to the outpatient clinic, for instance. Problems with clearing the secretions, very important. Morning headache can be due to the poor quality of the sleep, or it can be due to the increased level of carbon dioxide, which can occur during night. So if carbon dioxide increases, the vessels of the brain will dilate, they will expand, and the pressure inside the brain will increase as because of this. And this increased pressure will could result in morning headache, which gradually would tend to be more to diminish during the day. By the same reasoning, the appetite during the morning may be poor. And of course there are a lot of signs I would look for as a doctor that would confirm the suspicion that perhaps this patient now has a problem with his breathing. I'm not going to go into detail about that, but these are the criteria that I have to think about when I talk with a patient and try to evaluate whether I can do any useful with some kind of mechanical assistance, for instance, for the patient. So I need to try and ask for the symptoms, of course, and I try to evaluate the function of the respiratory muscles. You can do that in several ways. You can measure just the capacity to breathe, the power of breathing. We can do measurements during the night, like for instance the oxygen concentration in the oxygen saturation in the blood during sleep. And of course we can measure blood gases. Now, talking about treatment, the most common treatment is some kind of device that applies a positive pressure to the patient, either with a mask covering the nose or a mask covering both the nose and the mouth. So actually only a machine that is able to press the air and doing this also in synchrony with the patient. This is what we call positive pressure ventilation, and we call it non-invasive ventilation because it's nothing, you don't have to put any tube into the airways of the patient, it's only a mask. It's often abbreviated NIV, if you read about this, NIV, positive pressure ventilation. And of course, if the patient is not able to use a mask, if, for instance, the bulbar function, the capacity to swallow secretions is very diminished, it's very difficult to tolerate a mask. And then the only possible treatment as an alternative is tracheal ventilation, which we call invasive ventilation, because you need to have a tube put into the airways, a cannula usually. I'm going to show several pictures of that later. Now, obviously, regarding masks, there has been a lot of different options, and they are increasing by every year. And this is very fortunate, of course, because every patient is different regarding their nose, of course. So we need both different masks and different sizes of these masks. They have their disadvantages and advantages. Some of them are small, so you could use glasses, and some are bigger. Some masks cover both the nose and mouth. Of course, if you have weakened muscles in your jaws and are unable to keep your mouth shut when you are breathing, then you would need a full face mask, a mask covering both the nose and the mouth. These masks are not so many different masks to choose from as from the nasal masks. Fortunately, we have the different what we call templates, so we can try and measure the correct size of the patient without trying too many masks of the same kind in each patient. There are even masks covering the entire face. These are not very practical, but in some cases, for a short time period, they may be possible to use. In some very special cases, we also do custom-made masks. So we actually make a molding, like a cast of the nose of the patient, and this is a very durable mask, and it's very small and nice, as you can see in this picture as well. Tracheostomy, a very large selection of different cannulas, and they have, of course, the tracheostomy, it has advantages and drawbacks. The main advantages is, of course, that you are going to be able to give a more secure ventilation to the patient. You're going to be able to provide enough air to the patient even when he is dependent on support totally by the ventilator, which is more difficult if you are using a mask. A mask could always fall off the nose, or it could be obstructed from giving enough air to the patient if you have a lot of mucus. So if living the longest possible is the main preference of the patient, then of course tracheostomy is the treatment that is going to provide the longest life expectancy. The drawbacks, of course, is that it needs a lot more attending. And usually, most patients will need a team of helpers 24 hours during the day to provide this treatment at home. So it does make a very large change in terms of the home surroundings of the patient. It requires a lot more of people around in the house. That's one of the things. There are a lot of others, of course. Now, the principle of the tracheostomy is a simple tube or a cannula put inside the trachea, the main bronchus. And in some cases you have a second inner cannula that is disposable, so you can clear from secretions. And very often in the ALS patients we are treating, they also have a cannula with a cuff. So you can secure secretions from falling from the throat and down into the lungs. In some cases a fenestration, but that's not very common in the ALS patient. This is a hole in the cannula that can be used for making the patient able to speak if he has enough function in his larynx to make a voice. Regarding ventilator choices, there are a lot of different machines, and the clinician of course need to know the advantages of all of these different devices. What is most commonly used, initially at least, is the simple bi-level positive airway pressure devices, the BiPAPs. Those are the devices that are most easy to start treatment with. But there are several options. I will talk very briefly about it. I'll only show a few pictures. These are there's a lot of different bi-level devices available. These are some of them. You may know of them. The more sophisticated equipment, the ventilators that have internal batteries and alarms and that can be used in patients with a tracheostomy are not so many as the BiPAPs, but still there is quite a lot of them as well, as you can see. Obviously, at each center you don't need to know about all of these ventilators. Usually they will have 2 or 3, perhaps 4 different ventilators that they are familiar with. That would be enough. We also have, in addition to machines that can help to clear secretions, like an ordinary suction machine, there are also some machines that can assist coughing, like this machine here. I think it's on the stand outside here. Now, choosing among the different ventilators, it's to some extent the question of how much ventilatory support does the patient need. Is it only a problem when you are sleeping, or is it a problem also that is present during daytime? So obviously, if I only need help with breathing while I'm sleeping, then I don't need such a sophisticated treatment perhaps as if I'm going to need treatment during daytime as well. Of course, during daytime I would like to go outside of my home. So I would need a ventilator that had an internal battery, for instance. So in this end of the spectrum, if you are treating patients that are using the ventilator only during night, it's always the BiPAP that is going to be the first choice. However, as the disease progresses, to some extent, it would be more practical to use a more sophisticated ventilator with an internal battery. They have also more alarms, etc. And if you are going to later choose treatment with a tracheostomy, then you would always need a more sophisticated ventilator. You could not use a simple BiPAP device. Some of the same things regarding the choice of a mask or a tracheostomy. Now, if it's important that you should live long, or if the treatment should be completely free of, or as a low hazard as possible, then tracheostomy will be the most secure thing to do. But it's also the most resource intensive treatment. So, but as the disease progresses, that's some of the things that one need to consider. Now in Norway, it's mostly pulmonary physicians that work together with the ALS clinic in evaluating patients and providing the kind of respiratory treatment that is necessary. In some places, however, you will find neurologists that are doing also this task, and in very few places in Norway also a few anesthesiologists. It's not so common in Norway as in Denmark, where that in fact is the most common thing. A few hospice services, and you have already heard about that from Peter, exist, and of course I see my patients both in the outpatient clinic and inside the ward and also at home. But this differs a lot between different parts of Norway. The equipment is paid by the hospital for the most part. However, the resources necessary for home care regarding the caregivers, that's the responsibility of the primary healthcare services. So it's a municipal responsibility. And this can be quite costly if it's a team of workers on a 24-hour shift that is established. So it's a cost of about 2 million Norwegian kroners a year just to have all these people working. Fortunately, there is some degree of support from the state if you are all less than 60 years old. In my experience, it differs a lot between different patients, how these teams are established. In some cases, you will find a mixture of healthcare personnel, like a nurse or a nurse assistant, and in some cases, you will only have unskilled labor doing the caregiving for the patient. We do have the same thing that is available in Denmark and in Sweden with personal assistance, and there is also an organization that may take care of the responsibility for these personal assistants if the patient does not want to have this responsibility himself. It's called Bulbar, the patient organization. And the team will usually be a mixture of all these people, and of course with the patient as the chief. Now the skill of the caregivers is the primary responsibility of the hospital to secure that they have the necessary skills to take care of the patient. And this should be provided and certified by written statements. Now some very simple data on the current situation in Norway. We have a national registry that is established at our hospital. We collect information regarding all ventilated patients in Norway, not only ALS patients, but all patients. And as of September, we have registered 66 patients on home mechanical ventilation in Norway. And for the last 3 years, because it's only 3 years that we have had this record, we have had 100 patients with ALS. So 1/3 of the patients, 34 patients, are dead. Out of the living ALS patients, 1 out of 3 patients are tracheostomized. Prevalence, that is the number of patients among a certain amount of inhabitants, about 2 per 100,000 above 30 years. But there are large differences between different counties. So in some counties we have more than 5 per 100,000. So there are obviously still a lot of different opinions regarding how important this treatment is to the patient. The typical patient is about 60 years, and there is a very large overweight of male to female patients. Currently, I think the longest treated patient is about somewhat over 9 years. On average, the patient in our register currently has been treated slightly above 2 years. As you can see, ALS patient is only a small group, although a very important group of the entire population of patients with a ventilator at home. Tracheostomy, 1/3 of the patients, and this is the male dominance, if you like. This has of course something to do with males in general being affected more than women, but I think this is still somewhat more than we should expect. 3 times more males than women, that's a bit high, I think. The distribution of age, the patients are quite old, as you can see. Most of the patients are treated with these simple devices, as I told you, the bilateral devices, using only a mask, and the other 40% of the patients have more sophisticated ventilators. Some challenges, I think, the Bulbar patient, that is the patient that has a problem with the throat and the ability to swallow and get rid of their secretions. Those are also very difficult to treat non-invasively. They will have big problems tolerating a mask. And for obvious reasons, if the secretion is lying back in the throat and I try to put the mask over the mouth or the nose, it will be very discomfortable trying to breathe when you are having something back in your throat. So this is a very big challenge, and often it's not possible. Then there is the question of tracheal ventilation. It is something that is going to provide secure airways, but it's also a complicated treatment, and we do know that it can be a burden for the family, even though you have managed to establish a team of caregivers and everything seems to function all right. We know for a fact that it's very difficult to get this up and running properly on a daytime. There's always things like illness or vacation or whatever. It's difficult actually to get enough people, so it can be quite stressful in some cases, even though the primary healthcare is doing its best to provide enough resources. In some cases, they don't simply do their best, and that's of course another problem. I think also it is important to acknowledge the fact that we as healthcare professionals are not the right people to make assumption about the quality of life and the preferences of the patient. So we need to make the patient able to make the right choices, but that is also has something to do with making the patient able to, or giving the correct information to the patient, of course. So I think the patient eventually, of course, must decide, but he needs a very comprehensive information regarding the advantages and disadvantages of tracheal ventilation. And I think, of course, it is a challenge that as the disease progresses, you might also end up in a state where you're unable to communicate, what we call a locked-in state. So it's very important to have an agreement with the patient, what we call an advance directive, so that we are able to know for sure what the patient would want us to do if an acute situation occurs, or if one should reach a state of very progressed disease, like the locked-in state. I think also it has been shown last few years that ALS patients, unfortunately, it's not only a disease that only affects motor neurons, the ability to move your muscles, but to some extent, in some patients, also can affect the cognition, the cognitive function. And if you don't talk with the patient enough about the important questions at the stage when you are able to, when the patient is able to give his opinion, then and you wait and you with these kind of important decisions, then of course you will have a very big problem if the patient has a cognitive dysfunction, develops that later in the disease. So I will end up with some practice point. I think it's very important to check symptoms and signs of respiratory failure when I'm seeing each patient. We measure lung function if it's possible, and we do a few recordings on a regular basis. If symptoms arise about respiratory failure, then of course it's important to discuss with the patient the consequences, the possibilities of each choice you are making, and the consequences of the choices you are making. We always consider the simple treatment, the mask treatment, before the complicated treatment. And in summary, I would like to say that for the 3 years that the register has been recording home ventilator patients, we have seen an increasing number of ALS patients choosing ventilatory support, but there are still large inequalities across the geographic regions in Norway. And the choice of ventilatory support depends on the patient preferences, obviously, I think. Mask ventilation should be offered to all patients, but tracheostomy I think is a treatment option for some patients, and only after careful consideration and repeated discussions, trying to establish the advantages and the disadvantages. Thank you.